Hey guys, welcome back to my channel. Thank you so much for clicking on this video. If it is your first time of coming across this channel, my name is Becca. I'm an overseas nurse from Ghana, currently practicing and living in England. And in today's video, I'm going to be talking about your duties, responsibilities, salary, career advancement, and everything you need to know about being an endoscopy nurse. And this video is a special request following my video that I vlogged on a typical day in my life as an endoscopy nurse, and lots of people have DM'd me saying they are nursing placement in endoscopy unit. Others are looking forward to going into endoscopy. Others have received job offers in the endoscopy suite, and they really want to know what it is like to be an endoscopy nurse before they go into this kind of setting. If it is your first time of coming across this channel, do well to subscribe down below, turn on your post notification bell icon, that way you wouldn't miss anytime I upload a video. To go ahead and check out my other videos in my playlist that basically talks about nursing here in the UK, because this is where my specialty lies. So without much ado, let's go right into the video. I'm going to begin with the shift pattern or the work pattern, the number of days you're supposed to work and how the shift is run. And everything I'm going to be saying is based to endoscopy nursing in the UK. You are contracted for 37.5 hours, which is the standard for any NHS nurse. And let me say this before I continue. If you are the kind of person that doesn't want to be running shifts like morning or long day, early night and those things, endoscopy is one of the best specialties you would like to go into, okay? So endoscopy doesn't run shifts like nights and weekends and long shifts and all those things. So you are contracted for 37.5 hours per week. And you start work at 8 o'clock a.m. and you close at 6:30 in the evening, or you start at 8:30 in the morning and you close at 7 p.m. So there'll be like one day in a week that you're going to be working from 8:30 to 7, and the rest of the 3 days you're going to be working from 8 to 6:30. So you work 4 days in a week. Now, if you do your calculation, if you're going to be working from morning, that's 8 a.m. till 6:30, or 8:30 till 7 o'clock in the evening, you are going to be working like 40 something hours a week. The NHS gives you 30 minutes of unpaid break out of these hours. So if you deduct your 30 minutes of unpaid break, you are left with 10 hours per shift. So in a day, you're going to be working for 10 hours. If you multiply this by the number of days you're going to be working, which is 4 days, it means you're going to be working for 40 hours, which is more than your contracted hours, okay? So what happens is that for 1 week in a month, you are going to be working 3 days instead of 4 days, which balances for your time loss or for your extra time. Mind you, if you overwork, the NHS mostly doesn't pay you for overtime if it is not stated in your contract. So you have to work within your contracted hours unless you have chosen to work as overtime for that. So most of the times they consider this as time owing, and to compensate for this, it is going to be giving you as a day off. So for 1 week in a month, you are going to be working for 3 days instead of 4 days, which compensates for your overtime or your extra hours you've been working. Still on the shift pattern, we have what we call the emergency on-call or the emergency response team. So this is basically a pair of nurses who are going to be on emergency standby just in case a patient develops upper GI bleeding or a life-threatening situation that cannot wait till the next morning. Because mind you, the unit is not opened at night. So from 6:30 to 7, when you've all closed, the unit is basically shut down. But there still needs to be somebody who is on standby just in case there is an emergency in theater or in ITU and the patient needs to be scoped. So every single day of the week or of the month, there are 2 nurses that are going to be on emergency standby, which we call the on-call or the emergency on-call. So 2 of you are going to be on call with 1 consultant. And if there is a case in theater or in ITU that is life-threatening, that cannot wait till the next morning. For instance, if a patient has an upper GI bleed, the patient is pouring blood, HB is dropping, this patient has varicose bleed, cannot wait, it's life-threatening, you need to go ASAP and attend to this patient. So it is you, the nurse, with your other colleague and the consultant that is going to attend to this patient. So what happens is, if you are on call after your shift, you go home, but you are on standby. If you are not called for any reason, life goes on for you. If you happen to be called out at any point in time, even if it is 2 a.m., 1 a.m., 12 midnight, any point in time, you need to get to the scene ASAP, and you are given 30 minutes to get to the scene. So your phone has to be as loud as it can. Sometimes also you can be on call for weekend, that is Saturday, Sunday, because Saturday, Sunday, the unit doesn't run, but somebody needs to be on call just in case something happens and you need to be there to save the situation. Next thing I'm going to be talking about is the kind of procedures that we do in endoscopy and your duty as an endoscopy nurse. So the kind of procedures that we do respiratory procedures like bronchoscopy. We do GI procedures like ERCP, which is endoscopic retrograde cholangiopancreatography. We do esophagogastroduodenoscopy, or called the gastroscopy. We do the colonoscopy. We do flexible sigmoidoscopy. And these procedures can be categorized into therapeutic or diagnostic. So for the therapeutic, let's say a patient has a varicella bleed or a pancreatitis or something, you have to do the ERCP. You can do banding, you can do stent insertion. If a patient has an upper GI cancer, like an esophageal cancer, cannot swallow, you can do the stenting, which is literally putting a metal into the esophagus to open it up for food to be able to go down the throat. If a patient has a food bolus, you are going to be removing the food from the throat, which is a foreign body in the throat. If a patient has respiratory conditions like tuberculosis or chronic bronchitis, you have to do bronchoscopy for this patient. So for the diagnostic, you basically diagnose cancers, you basically diagnose inflammations, you basically diagnose bleedings. One of your first and foremost duties is to make sure that the patient is safe and comfortable throughout the procedure. So before the procedure, we have what we call the pre-assessment. So you call these patients on the phone and you assess them. Prior to the COVID, they were coming into the unit to physically inspect and to have a talk with, the endoscopy nurse, to brief them on what was going to be happening or what they should expect. But when the COVID came, you have to call them on the phone and explain the procedures to them, what they are coming to do, whether they want to have sedation or not, whether they are taking certain medications that needs to be stopped. So for instance, a patient is coming for a procedure, the patient has a pacemaker, the patient is taking a blood thinning medication, and the procedure is a procedure like a colonoscopy. This patient is going to be using the scope guide. The scope guide doesn't agree with the pacemaker. There's a pacemaker that needs to be turned off. It means you have to call the cardiologist ahead of time for them to come in at the time that the patient is going to be admitted on the day of the procedure to turn the pacemaker off. Otherwise, this patient cannot come for the procedure. And it's going to be very disappointing for a patient to come from home expecting to do a procedure, and because the patient wasn't properly pre-assessed, the patient cannot have the procedure. So you have to call cardiology to come in to turn off this pacemaker so that the patient can have the procedure done. If the patient is taking blood thinning medications like clopidogrel, like warfarin, all those kind of blood thinning medications, they have to be stopped at some number of days. So like, let's say if they're taking warfarin, they have to be stopped certain days before the procedures, depending on the kind of procedures they are coming to do. So you have to call them, ask them all these bits and pieces, whether they've had a heart attack before, if they have atrial fibrillation, you know that you're going to be monitoring them in a special way throughout the procedure. If they smoke and they're coming for gastroscopy, they have to stop smoking hours before the procedure. All these things needs to be explained to them. If they're coming for lower GI procedures like colonoscopy, you know that their dignity is going to be compromised. So you have to explain to them. If they need to bring in a dressing gown, if they want, they can bring in a dressing gown. You basically take them, walk them through the process and the procedure and everything that they need to know. In the unit, it is your duty to set the room up and to make sure the logistics and stocks are available at every point in time. So for instance, you know that these patients use sedation. You don't need to wait till the sedation is almost or nearly finished before you go running about, you need to make sure that the sedation is always available. You draw the sedation and make it ready. You are the one going to be administering the sedation if you have been trained and competent to do it on the day of the procedure. You are the nurse going to be setting up the room. So you set up the scope, you set up the room, you set up your emergency drugs, you set up your sedation, you make sure that the system, the computer, the image capturing is working, the water pumps are working, the suction tubings are ready and they are working, your mouth suctions are working, your trolley is working, the oxygen is available and is working. There are a lot of things I can't touch on, but basically everything in the room needs to be working. So from the time you start duty at 8 o'clock till somewhere around 8:30, the room should be ready for the patient and the consultant should be followed up on. So it is your duty again to follow up on the consultant, communicate with them. We are having so and so patient, he has a pacemaker. Trust me, sometimes because of the pressures, they do not check, and you are going to be like the second eye for the doctors. So you're going to be checking the patient is going to be having a lower procedure, whether they've had their bowel cleaned, because you don't want the patient to come and lie on the trolley filled with poop in the bowel. The bowel has to be cleaned, so they have to take their bowel preps. If it is enema they are going to be receiving, the enema has been given. The patient is really ready for the procedure. Consent form has been signed by the patient. If the patient doesn't have capacity, the next of kin or the person that has the lasting power of attorney has signed the consent form. So with the consent form, we have two types of consent. We have the consent form 1 and the consent form 4. The consent form 1 is for patients that have capacity that can consent to the procedure. And if we say patient who has capacity, it basically means patients who are able to retain information and who are able to understand and give consent and sign. Even if the patient is not able to physically sign, as far as they can be able to retain the information and tell you back and understand what has been said, you, the nurse, can act as a witness and append your signature in addition to the doctor's signature to be a witness for the patient. But if the patient doesn't have capacity, let's say a patient with dementia doesn't have capacity, or a confused patient, and you still need to scope, this patient has to have a consent form 4. So you have to make sure that the consent form has been signed, which needs to be discussed with the next of kin or the person that has the lasting power of attorney to make decisions on behalf of the patient. This person needs to sign the consent form with the doctor or the consultant who is going to be doing the procedure, and you have to make sure that the consent form has been signed before the patient is put on the trolley for the procedure to be done. Once the procedure is happening, once the patient is in the room, there are going to be two of you in the room, so you and your other colleague. So one of you is going to be with the consultant scoping and doing all the bits. So if, let's say, the patient or the consultant wants to take a biopsy, your colleague or you, whoever is with the consultant, is going to be passing on the biopsy things. You are going to be taking the biopsies, labeling the samples, everything. And then the other colleague who is going to be looking after the patient, your duty is to make sure the patient is stable throughout the procedure. So you are going to be monitoring the observations of the vital signs very closely. Sometimes you give the sedation and the pulse drops. Sometimes you give medications like Buscopan or hyoscine butyl bromide and the heart rate increases. You are going to be monitoring the patient throughout the procedure, stabilizing the patient, communicating with the consultant and everybody in the room about the observations of the patient. You're going to be making sure that the patient is receiving oxygen if they are having sedation. You are suctioning your patient if it is a gastroscopy. Sometimes also the patient feels that once the scope goes down the throat, they can't breathe and they are going to be dying. It makes them anxious. They go into panic attack. Trust me, it is real. So you have to make sure the patient is well informed. You are talking to them throughout the procedure. You are explaining to them. You are telling them to be stable. Concentrate on their breathing. They should breathe in through their mouth. They are not going to choke. They are not going to die. Talk them through the procedure. Engage them in conversation. If it is a colonoscopy, the patient doesn't have anything in their mouth, so you can chat with them. Some of them are very chatty. That is where you can see people telling you all their life history, like from A to Z, just to take their mind off what is going on at the other side of their body. So you have to be good in communication, talking to your patient, alleviating their fears. Next is career advancement in the endoscopy unit. Right. So if you want to progress in endoscopy, you are starting as a band 5 and you need to go up the ladder unless you are happy to be where you are. I know quite a number of people who just want to be band 5 and nothing else. Nothing you do is going to move them from band 5 to band 6. They have been band 5 for more than 15 years and they are comfortable and they are okay because they don't want to be bombarded with responsibilities. But if you're the kind of person that wants to progress in your career, then this is for you. So endoscopy is a specialty, and for somebody to be promoted or for somebody to be brought on board as a band 6, 7 or something, they should have experience already in the endoscopy unit. And that makes it better for you. So once you're band 5, that is a brilliant opportunity for you to learn, for you to cope, for you to mingle with other members of the team, the consultants, the specialists, communicate with them, be assertive, be proactive, be smart, learn hard. If you have management certificate or if you have any certificate in management, it's going to be a plus for you. Now, in UK, I'll talk about this in a separate video, but let me just touch on it. In this part of the world, promotions are not automatic. So you have to see the position and know that you qualify for it, or you know that you suit or you are perfectly fitting into this position and apply for it. So after you've been a band 5 for like a year or two and you feel that you've learned enough, you are assertive enough, you are proactive enough, and you know you can move in your career, you can start applying for band 6 position. Same if you're band 6 and you want to apply for band 7, you can do so. You have to literally look for the position and apply for them. Okay. But before then, you learn enough and you prove yourself so that it gives you a better chance of winning or being able to be accepted when you go for the interview. If you want to specialize within this specialty unit also, we have specialty programs like the stoma nursing, which is basically just looking after patients with stomas. So a patient with ileostomies, colostomies, and all those things, you will be looking after them, whether in the community or in the hospitals. You can be a PEG specialist nurse. So PEG insertion, caring of the PEGs, everything concerning PEGs, PEG assessment. You will be the specialist nurse looking after patients with these special needs. You can also do what we call the bowel cancer screening nurse. So with the bowel cancer screening, the UK is very ahead of picking up cancers. So they basically go into the communities to get people to screen them for cancers. And the bowel cancer screening nurse gets these people to bring them into the endoscopy suite to be screened for cancers. We also have what we call the nurse endoscopist. So the nurse endoscopist is just like a consultant or a doctor. So your duty as a nurse endoscopist is to scope just like the doctor scope. So you are going to be able to put the scope down the patient throat or the back passage or wherever, scope like just like any doctor will do. And with this being said, if you want to go into this specialty, you need to already have the background in endoscopy for at least one complete year, so that you can go to school to be trained to become a nurse endoscopist. And with a nurse endoscopist, you are like a band 7 or 8, a band 8A. Salary is good. The course is, I think, 18 months for you to become a certified nurse endoscopist. And sometimes the trust sponsors you. So the trust funds you and gives you the permission to go to school. So it's just like a steady leave with pay. So you are working and schooling at the same time. You come back and the certificate is recognized because you were permitted to go to school. Last but certainly not the least I'm going to be talking about is salary of an endoscopy nurse. Everybody knows that nursing has never been a good paying job. So just like any band 5 across all NHS trusts, this is going to be your salary before tax deduction. If you are in London, this is how much you're going to be paid before tax deduction per annum. However, there are other ways of maximizing your income as an endoscopy nurse. And the first of all is to be an agency nurse for endoscopy. So if you are an agency nurse for endoscopy, Before you even become an agency nurse for endoscopy, you should have at least 1 year of relevant experience. It means you should be in endoscopy unit for a continuous 1 year and be deemed competent of doing the procedures and setting up the rooms for various procedures. Okay, so if you are going to be an agency nurse in endoscopy, these are some of the rates you are going to be paid. Sometimes you are lucky, you'll be in the unit for 6 months, 8 months, and you can be lucky to get some agencies that are ready to pick you up to work with you. If you are an endoscopy nurse, most of these agencies pay for your accommodation and your transport to wherever you are going to be working. If you are driving, it's a plus for you because the agencies pay much, much better. So if you are looking for a flexible work environment, to be able to do your school rounds, to be able to look after your family and not run shift like night duties and everything, you can consider endoscopy to be one of the best specialties for you. In my next video, I'm going to be sharing with you my personal pay slip or my personal salary as an endoscopy nurse. If you are interested, you just need to turn on your post notification bell icon so that if that video is ready, you are going to be seeing it with me. With this being said, you guys, I love you so much, and until we meet again in my next video, is bye for now. Adios.